Welcome to the Hospital Medicine Unplugged podcast.
It's great to be here.
Today we're tackling a really critical topic, one that every hospitalist encounters and needs to manage decisively. Heparin-Induced Thrombocytopenia, or HIT. This is definitely a condition where, well, time equals life and limb.
Absolutely, it's high stakes.
Our mission today is to really dig deep into the complex pathophysiology of HIT, get comfortable with using the 4Ts score for rapid diagnosis, and most importantly, solidify those evidence-based management strategies to prevent the really catastrophic thrombotic events we can see.
Right, and the core thing to grasp right from the start, as you mentioned, is just how paradoxical HIT is.
Exactly. It's this immune-mediated condition where the platelet count drops thrombocytopenia, but instead of causing bleeding, it actually triggers a massive prothrombotic state. The patient becomes hypercoagulable.
A huge risk for clotting, not bleeding. That fundamental paradox really drives everything else, especially the urgency.
It really does.
Yeah.
If you even suspect HIT, the response has to be immediate and absolute. The guidelines, the evidence, they all mandate that the very first step, without question, is stopping all heparin products.
And that means everything. Unfractionated heparin, LMWH, yes, but also those often overlooked sources like heparin flushes for 5E lines or even heparin-coated catheters. Any ongoing exposure is fuel on the fire.
It's crucial. But stopping the heparin while necessary isn't sufficient on its own, is it?
Not at all. You have to immediately initiate a therapeutic-dose alternative anticoagulant.
And this seems to be a common pitfall, maybe the biggest initial mistake. Underdosing that alternative agent.
It certainly can be. Giving just a prophylactic dose is simply not enough. The underlying pathology here involves massive, uncontrolled thrombin generation. You need a full therapeutic dose of a non-heparin agent right from the moment you suspect HIT. You can't wait for lab confirmation.
Okay, so immediate heparin cessation, immediate therapeutic non-heparin anticoagulation. Got it. To really manage this effectively, we need to understand why this happens. Let's dive into that immunological mechanism. How does the immune system essentially turn the body's own platelets against itself?
Well, it starts with this interaction between two molecules. Platelet factor 4, PF4, you might also see it, called CXCL4, is released from platelet alpha granules. It's a highly cationic protein.
And heparin is highly anionic.
Precisely. So PF4 binds very strongly to heparin. This binding creates what we call a neoepitope, basically a new structure on the surface of this complex that the immune system hasn't seen before and recognizes as foreign.
So the body mounts an immune response.
Yes, it produces IgG antibodies specifically targeting this PF4 heparin complex.
And these IgG antibodies aren't just cleaning things up, they're actually triggering a harmful cascade.
Exactly. These immune complexes, the PF4 heparin G combination, then bind to a specific receptor on the surface of platelets, the Fc gamma R2A receptor. When they bind and cross-link these receptors, it's like flipping a switch.
A switch for potent platelet activation.
Potent activation, aggregation, and crucially, the release of procoagulant platelet microparticles. This is what causes the platelet count to drop. They're being consumed and activated, but it's simultaneously the engine driving the thrombosis.
So the immune response, aimed at what it thinks is an invader, ends up massively amplifying the clotting cascade.
That's it in a nutshell. And it becomes a vicious cycle because activated platelets release even more PF4, feeding back into the process. Plus, this activation boosts tissue factor expression, which then activates monocytes and endothelial cells. The end result is this system-wide, profound prothrombotic state with excessive thrombin generation everywhere. That's why clotting happens even with low platelets.
That mechanism really highlights the danger. Now, it's absolutely critical we distinguish between type 1 and type 2 HIT. They often get confused, but they're completely different beasts clinically.
Very different. Type 1 HIT is essentially a benign phenomenon. It's non-immune mediated. You might see a mild transient dip in the platelet count, usually staying well above 100,000 per millimeters cubed.
And it happens early on.
Yes, typically within the first day or two of starting heparin. It seems to be just a direct non-immune effect of heparin causing some platelet clumping.
So the key takeaway for type 1 is, it's not an immune reaction, there are no antibodies involved, and importantly, there's no increased risk of thrombosis.
Correct. The platelet count usually recovers on its own, even if you continue the heparin. The real danger with type 1 is actually over-diagnosing it as type 2 and putting the patient through unnecessary, complex, and expensive alternative anticoagulation.
Okay, so all the clinical significance, the danger, lies with type 2 HIT, the immune-mediated process we just described.
That's the one. Type 2 HIT is defined clinically by that significant drop in platelets specifically, a fall of more than 50% from the baseline value, or from the highest platelet count measured after starting heparin.
And what's the classic timing for type 2?
The classic window is 5 to 10 days after initiating heparin therapy. That's when the antibody response typically mounts and becomes clinically apparent.
But there are important exceptions to that timing, right? Scenarios where it can happen much faster or even later.
Yes, and these are crucial not to miss. Rapid onset HIT can occur if a patient has had recent heparin exposure, usually defined as within the last 100 days or so.
Because they might already have antibodies circulating.
Exactly. If they have pre-existing antibodies from that prior exposure, re-exposing them to heparin can trigger a dramatic platelet drop very quickly, sometimes within just 24 hours. That's why getting a good history about recent heparin use is so vital.
And then there's the opposite scenario, delayed onset HIT, which can be really confusing because the heparin has already been stopped.
Right. Delayed onset HIT is less common, but it's tricky. It happens days, sometimes even weeks, after heparin has been discontinued. It seems to be driven by persistent antibody activity. The patient might even be discharged home and then present later with a new DVT or PE and thrombocytopenia.
So whether it's rapid, classic, or delayed onset, type 2 HIT is always associated with that very high risk of thrombosis, both venous and arterial, and demands that immediate therapeutic intervention.
Always.
Okay, moving to the bedside then, let's talk about how type 2 HIT typically presents clinically.
The hallmark lab finding, of course, is the thrombocytopenia. That characteristic platelet nadir, the lowest point, usually falls somewhere between 40,000 and 80,000 per millimeters cubed.
But the defining feature is the relative drop, the greater than 50% fall.
Correct. And while the drop is significant, it's actually rare for the platelet count in HIT to plummet below 20,000 per millimeters cubed. If you see a count that low, while you still consider HIT, you should also be strongly investigating other potential causes like DIC, sepsis, TTP, things like that.
And we have to keep hammering home that thrombotic paradox. Low platelets usually make us worry about bleeding.
But here, bleeding is rare. Petechiae are seldom seen. The real danger, the dominant clinical feature, is thrombosis.
How common is thrombosis in confirmed HIT?
Alarmingly common. Up to 50%, half of patients with confirmed type 2 HIT will develop a new or worsening thromboembolic complication. It's fundamentally a thrombotic disease.
And the consequences are severe.
They are. Mortality rates in modern series still range from 5% up to maybe 18%, and that mortality is overwhelmingly due to these thrombotic events.
Where do these thrombotic events most commonly occur?
The most frequent sites are venous, so DVT and pulmonary embolism are very common, but because it's a systemic prothrombotic state, you can see thrombosis anywhere.
Arterial sites too.
Yes, less common than venous, but significant. Peripheral arterial thrombosis leading to limb ischemia, ischemic stroke, even myocardial infarction. And importantly, HIT can cause thrombosis in unusual locations that might be missed if you're not thinking about it. Places like the cerebral venous sinuses or the splenic veins presenting as severe abdominal pain or unusual neurological symptoms.
And you mentioned earlier, sometimes the thrombosis actually shows up before the platelet count drops significantly.
Yes, that's a really important point. In maybe up to 25% of cases, the patient develops the new clot, the DVT, the PE, before their platelet count has officially dropped by 50% or fallen below a certain threshold. It underscores why clinical suspicion is paramount, sometimes even more so than the absolute lab value early on, especially when evaluating a new clot in someone on heparin.
Are there other, maybe more subtle, clinical clues besides those major thrombotic events?
There are. You might see clues related to microvascular thrombosis. Necrotic skin lesions at heparin injection sites are one classic sign. These often look like painful, purplish patches that can unfortunately progress to full skin necrosis.
Indicating clot formation in the small vessels of the skin.
Exactly. And then, much more rarely, some patients can have acute systemic reactions, things like fever, chills, tachycardia, shortness of breath happening within about 30 minutes of getting an IV heparin bolus. This likely represents a very acute, severe systemic immune activation when the drug is reintroduced.
Okay, that paints a clear picture of the presentation. Let's pivot to risk factors and prevention. Understanding who is most at risk helps us target monitoring and potentially choose alternatives up front. What are the key risk factors?
The single biggest factor influencing risk is the type of heparin used. Unfractionated heparin, or UFH, carries a significantly higher risk, roughly 10 times higher than low molecular weight heparin, LMWH.
What kind of numbers are we talking about?
With UFH exposure, especially for 6 days or more, the risk is typically in the range of 2 to 3%. With LMWH for the same duration, the risk is usually less than 1%, often much lower.
And why the difference?
It's thought to be related to the molecular size. UFH is a larger molecule and binds more readily and avidly to PF4, creating more of those immunogenic complexes compared to the smaller LMWH molecules.
So a key prevention strategy is simply preferring LMWH over UFH when it's clinically appropriate and feasible.
Absolutely. Minimizing duration of any heparin exposure is also key. The risk definitely increases with longer exposure, particularly beyond that 4 to 5 day mark.
What about patient populations? Does risk vary significantly there?
It varies dramatically. Surgical patients are generally at the highest risk, particularly those undergoing major cardiac or orthopedic surgery. Their risk can be anywhere from 1 to 5%.
Why so high in that group?
It's likely multifactorial, large amounts of heparin used during the procedures, massive tissue factor release from surgical trauma, a generally pro-inflammatory post-op state. Medical patients or obstetric patients, on the other hand, have a much lower risk, typically in the 0.1 to 1% range.
Any difference based on sex?
Yes. Interestingly, data consistently show that women have about twice the risk of developing HIT compared to men. The reasons for that aren't fully clear.
Given these risk stratifications, especially for surgical patients, what's the recommended approach for platelet monitoring to catch HIT early?
For patients considered at moderate or high risk, essentially anyone with a baseline risk estimated over 1%, which includes most major surgical patients on heparin, the guidelines recommend monitoring platelet counts every 2 to 3 days.
And when should that monitoring start and end?
It should specifically start around day 4 of heparin exposure and continue through day 14. That window covers the typical time frame for developing type 2 antibodies and seeing the platelet drop.
And for lower risk patients, like most medical patients.
For those low-risk groups, routine scheduled platelet monitoring may not be necessary or cost-effective. The focus there is more on minimizing the duration of heparin therapy overall and being vigilant for clinical signs rather than just serial lab checks.
Okay, that makes sense. Now let's move into the diagnostic strategy. A patient on heparin develops thrombocytopenia. We need a structured approach. The 4T score is central here.
It is absolutely the mandatory first step. The 4T score is a clinical probability tool. It's simple, it's validated, and its main strength is its incredibly high negative predictive value.
Meaning it's great for ruling HIT out.
Exactly. A low 4T score, which is 0 or 1 point total, makes HIT highly unlikely. The negative predictive value is around 99%, so if the score is low, you can confidently look for other causes of thrombocytopenia and avoid unnecessary testing and treatment for HIT.
Let's quickly recap the 4T domains that we score.
Sure. The first T is the degree of thrombocytopenia. How much did the platelet count fall? Is it more than 50% or less? What's the nadir? The second T is the timing of that fall. Does it fit the classic 5-10 day window, or is it rapid onset, suggesting recent exposure or perhaps delayed? The third T is the presence of thrombosis or other sequelae like skin necrosis or those acute systemic reactions. And the final, very important T is considering other potential causes for the thrombocytopenia. Could it be sepsis, drugs, DIC?
And based on the points assigned in each domain, we get a total score classifying risk as low, intermediate, or high.
Correct. Low is 0-1 points, intermediate is 2-3 points, and high is 4 to 8 points.
So if the 4T score comes back intermediate or high, that triggers the next step, the laboratory testing pathway. But what's the critical action we take immediately based on that score, even before labs are back?
This is crucial. If the 4T score is intermediate or high, you must act as if the patient has HIT until proven otherwise. That means stop all heparin immediately, initiate therapeutic-dose non-heparin anticoagulation without delay, and then send off the laboratory tests, starting with an immunoassay. You cannot wait the hours or days for lab results before starting treatment. The risk of thrombosis is too high.
Okay, so treat first based on clinical suspicion if the 4T is intermediate high. Let's talk about that first lab test, the immunoassay, usually the PF4 heparin ELI assay.
Right. The immunoassay, like the ELI assay, is designed to detect those HIT antibodies, the IgG, bound to the PF4 heparin complex. These tests are very sensitive.
Meaning a negative result is reliable.
Highly reliable. If the ELI assay comes back negative, you can be very confident the patient does not have HIT, stop the alternative anticoagulant you started empirically, and investigate other causes. It's an excellent rule-out test.
But the flip side is the challenge. A positive result.
Exactly. Here's the key caveat. A positive immunoassay does not definitively confirm clinical HIT. Many patients, especially post-cardiac surgery or after prolonged UFH exposure, can develop these antibodies, but the antibodies might not actually activate platelets. They're present, but non-pathogenic.
So the ELISA has high sensitivity but lower specificity. How can we use the result to guide us while potentially waiting for more specific testing? Does the strength of the positive result matter?
It absolutely does. We look at the optical density, or OD, value reported with the ELISA. The higher the OD, the higher the likelihood that the antibodies are pathogenic and clinically significant. An OD greater than, say, 2.0 is strongly suggestive of true HIT. A weakly positive result with an OD closer to the cutoff, say 0.4 to 0.8, in a patient with only intermediate clinical suspicion might warrant confirmation with a functional assay.
Which brings us to the gold standard test for confirmation.
That would be the functional assays, with the serotonin release assay, or SRA, being the most widely recognized gold standard.
And why is it the gold standard?
Because it directly tests for the key pathogenic mechanism. The SRA measures whether the patient's serum, containing the antibodies, actually causes platelet activation using donor platelets and measuring the release of serotonin. It confirms that the antibodies present are indeed the dangerous platelet-activating type.
But it's not readily available everywhere, is it?
No, it's technically complex, often requires specialized reference labs, and has a longer turnaround time. So its main role is typically for confirmation after a positive immunoassay, especially if the OD was intermediate or low, or in cases where the clinical picture is unclear, and committing the patient to months of alternative anticoagulation is a major decision.
Okay, so to recap that diagnostic algorithm, if the 4T's score is low, HIT is effectively ruled out, just monitor. If the 4T's is intermediate or high, you immediately stop heparin, start therapeutic non-heparin anticoagulation, and order the immunoassay, like the ELISA. A negative immunoassay rules out HIT. A positive immunoassay, especially with a high OD, strongly supports HIT, and you continue treatment. Confirmation with an SRA might be needed in ambiguous cases, but treatment decisions shouldn't wait for it.
That's the essential pathway. Treat based on suspicion, use the ELISA to help rule out or strongly support, and reserve the SRA for confirmation when needed.
Perfect. Now let's drill down into the evidence-based management in that acute phase once we've made the presumptive or confirmed diagnosis. We've covered stopping heparin and starting alternative anticoagulation. What else needs immediate attention?
Two other key points in the immediate management. First, we generally need to avoid platelet transfusions.
That sounds counterintuitive again. The patient is thrombocytopenic. Why not give platelets?
Because in the context of HIT, transfusing platelets is like adding more fuel to the fire. You're providing more targets for those pathogenic antibodies to bind to, activate, and aggregate. This can paradoxically worsen the prothrombotic state and potentially lead to more microvascular thrombosis.
So platelet transfusions are generally contraindicated
Unless there's active, life-threatening bleeding, which again is rare in HIT, or if the patient absolutely requires an urgent invasive procedure where bleeding risk is extremely high, even with the alternative anticoagulant. Otherwise, avoid them.
Okay. And the second point for immediate management, screening for clots.
Yes. Given that high rate of thrombosis, including silent thrombosis, performing screening lower extremity duplex ultrasonography looking for DVT in all 4 limbs is recommended. Finding subclinical thrombosis definitely impacts the necessary duration of anticoagulation later on.
It upgrades them from isolated HIT to HIT with thrombosis, or HIT.
Exactly, which means longer treatment.
All right, let's talk about the specific non-heparin anticoagulants used in that acute parenteral phase. The choice often seems to hinge on organ function, particularly renal function.
That's a major deciding factor. Argatroban, which is a direct thrombin inhibitor, is very commonly used. Its main advantage is that it's cleared primarily by the liver, so it's often the preferred agent in patients who have significant renal insufficiency or kidney failure.
And how is argatroban monitored?
It's monitored using the activated partial thromboplastin time, the APTT. It's given as a continuous IV infusion, and the goal is typically an APTT that's 1.5 to 3 times the patient's baseline value, usually capped at around 100 seconds to avoid excessive anticoagulation.
What are some practical challenges with using argatroban, especially in sicker patients?
Well, because it's hepatically cleared, patients with liver dysfunction require significant dose reductions right from the start, maybe starting as low as 0.5 mics per kilo per minute instead of the usual 2. You also need frequent APTT monitoring, especially early on, to get the dose titrated correctly, and co-administered drugs can affect its levels.
And argatroban has that notorious interaction with the INR test, which complicates transitioning to warfarin later.
Yes, that's probably the biggest challenge in practice. Argatroban directly interferes with the lab assay used to measure the prothrombin time and calculate the INR. It falsely elevates the INR.
So the INR value you see on the lab report when a patient is on argatroban doesn't accurately reflect the level of anticoagulation from warfarin if you're trying to bridge.
Correct. It looks much higher than it actually is in terms of warfarin effect.
So how do we manage that transition safely? How do we know when the warfarin is truly therapeutic?
There's a specific protocol. When bridging to warfarin while a patient is still on argatroban, you need to overlap the two drugs and aim for a much higher target INR on the lab report, usually an INR between 4.0 and 5.0 for at least 2 consecutive days.
Because that artificially high INR accounts for the argatroban interference.
Exactly. Once you achieve that target INR of 4.5 while both drugs are running, you can stop the argatroban infusion. Then you need to wait about 6 hours for the argatroban effect to dissipate and recheck the INR. Only then will the INR reflect the true warfarin effect, and hopefully it will be in the therapeutic range of 2.0 to 3.0.
That requires careful coordination. Are there other parenteral options besides argatroban?
Yes. Danaparoid is another option. It's technically a factor ZAB inhibitor, though it has some other minor effects. It's approved for HIT treatment, and studies show good success rates, over 90%. It's monitored with anti-factor ZAG levels.
And what about patients with both kidney and liver problems?
That's a tough situation. Bivalirudin, another direct thrombin inhibitor, is sometimes used in those cases. Its clearance is a bit more balanced between enzymatic degradation and renal excretion, so it might be an option for combined hepatic and renal dysfunction.
We also see fondaparinux being used more often, though it's technically off-label for HIT treatment in many places.
Right. Fondaparinux is an indirect factor ZAZA inhibitor given subcutaneously. It's become increasingly popular, particularly for more stable HIT patients who have good renal function. The convenience of subcutaneous dosing is appealing, but it is primarily renally cleared, so it's not suitable for patients with significant kidney disease, like a CRCL30M element. Its use really depends on institutional protocols and clinician comfort, given the off-label status for treatment.
Okay, so several parenteral options depending on the clinical scenario. Now, let's discuss the transition to oral anticoagulation once the acute phase is managed and the platelet count starts to recover. This is where warfarin comes in, but with major warnings.
Extreme caution is needed here. Warfarin, being a vitamin K antagonist, is absolutely contraindicated during the acute phase of HIT when platelets are still low and recovering.
When is it safe to even consider starting warfarin?
There are 2 strict criteria that must be met first. 1, the platelet count needs to have substantially recovered, generally to above 150,000 per millimeters cubed. And 2, it needs to have stabilized at that level for at least 2 consecutive days. Only then can you think about initiating warfarin.
And why is starting warfarin too early so incredibly dangerous? You mentioned venous limb gangrene earlier.
It comes down to warfarin's mechanism. It inhibits vitamin K-dependent clotting factors, but it also inhibits the natural anticoagulants, protein C and protein S. Protein C has a much shorter half-life than some key clotting factors like prothrombin, factor 2.
So you temporarily knock out the brakes, protein C, before you fully knock out the gas, prothrombin.
Exactly. Starting warfarin early creates this transient but potentially devastating hypercoagulable state because you deplete the natural anticoagulant protein C quickly while the procoagulant factors are still high. In the already intensely prothrombotic environment of acute HIT, this can lead to widespread microvascular thrombosis, classically manifesting as venous limb gangrene, skin necrosis, and potentially limb loss.
A truly catastrophic complication from premature warfarin use. So assuming the platelets are recovered above 150,000 and we're ready to start warfarin, how long does that overlap period need to be with the parenteral agent like argatroban or danaparoid?
The overlap is critical for continuous protection. You must continue the therapeutic parenteral anticoagulant concurrently with warfarin for a minimum of 5 days, and until the INR, the true INR, after accounting for any argatroban interference, has been stable within the therapeutic range, usually 2.0 to 3.0, for at least 24 hours, some say 48 hours. This ensures the patient remains fully anticoagulated during that vulnerable early phase of warfarin initiation.
That's a demanding process. What about the direct oral anticoagulants, the DOACs? Are they changing the game for maintenance therapy after HIT?
They certainly seem to be. DOACs, particularly the direct factors-on inhibitors like apixaban and rivaroxaban, are being used much more frequently now for the transition and long-term management of HIT once the patient is stable and the platelets have recovered.
What are the advantages?
The major advantages are convenience and safety profile in this context. They don't require the complex overlap monitoring needed with argatroban and warfarin. They don't interfere with the INR. And crucially, they don't cause that initial depletion of protein C, so the risk of warfarin-induced skin necrosis or venous limb gangrene is avoided. You can generally start a DOAC once platelets are recovering, often concurrently with stopping the parenteral agent without needing a prolonged overlap.
So a much simpler and potentially safer transition once the acute phase is over and platelets are up.
Yes, emerging data supports their use, and they are becoming a preferred option for many clinicians in stable patients post-HIT recovery. Cost effectiveness is also often favorable compared to prolonged parenteral therapy or complex warfarin bridging.
Okay, finally for management, let's define how long patients need to stay on anticoagulation after they leave the hospital. Does it differ if they had a clot versus just the lab finding of HIT?
Yes, the duration depends entirely on whether thrombosis occurred. For patients with isolated HIT, meaning they had the platelet drop and confirmed antibodies, but screening did not reveal any DVT, PE, or other clot anticoagulation is typically continued at a therapeutic dose until at least platelet count recovery, with most guidelines recommending a minimum total duration of about 4 weeks. Some experts extend this to 3 months even without thrombosis, given the inherent risk.
And if they did have thrombosis, HITT?
For HIT complicated by thrombosis, HITT, the duration is much longer. These patients need therapeutic anticoagulation for at least 3 months, treating it similarly to how we treat other provoked venous thromboembolism. Depending on the nature and severity of the clot or other patient risk factors, sometimes longer durations might be considered.
Got it. 3 months minimum for HITT, roughly 1 month minimum for isolated HIT, often transitioning to a DOAC after the initial parenteral phase.
That's a good summary of current practice.
We've touched on the complications throughout, but let's just briefly summarize the major ones again, beyond the common DVT-PE.
Right. Thromboembolism in general is the biggest concern, venous, arterial, stroke, MI. But the really HIT-specific severe complications often involve that microvascular thrombosis.
Like the venous limb gangrene we discussed, especially with early warfarin.
Exactly. That's probably the most feared limb-threatening complication. We also can see adrenal hemorrhagic necrosis, basically bleeding into the adrenal glands due to thrombosis of the adrenal veins. This can cause acute adrenal insufficiency, presenting as shock, which can be fatal if not recognized. And as mentioned before, those necrotizing skin lesions at injection sites are another manifestation of the microthrombotic process.
It really underscores that this is a life and limb-threatening condition. What's the overall prognosis, and how quickly should things improve with proper treatment?
As we said, mortality remains significant, 5–18%, primarily due to thrombosis. The prognosis absolutely hinges on prompt recognition and correct evidence-based management. Avoiding missteps like premature warfarin or inadequate anticoagulation is critical. With the appropriate therapy stopping heparin, starting the right alternative anticoagulant at the right dose, we typically expect the platelet count to start recovering within about 7 days.
And if it doesn't recover?
If the platelets don't start to trend up within a week or so, you really need to reevaluate. Did we miss some ongoing heparin exposure? Is there another concurrent process driving the thrombocytopenia? Or, rarely, is the chosen alternative anticoagulant perhaps not fully effective in this specific patient, but usually recovery begins within that first week?
This has been an incredibly thorough deep dive into a complex but critical topic.
Yes.
Let's try to recap the absolute must-know points for our listeners.
Okay. I think number one is understanding HIT as that paradoxical prothrombotic disorder driven by platelet-activating antibodies. Low platelet, high clot risk.
Number 2, use the 4T score immediately for risk stratification. It's excellent for ruling HIT out if the score is low.
Number 3, if the 4T score is intermediate or high, act immediately. Stop all heparin sources and start therapeutic dose non-heparin anticoagulation without waiting for lab confirmation.
Number 4, understand the lab tests. Immunoassays, like ELISA, are sensitive rule-out tests, but positive results need interpretation, often using the OD value. Functional assays, like SRA, confirm pathogenicity but aren't always needed immediately.
Number 5, avoid platelet transfusions unless absolutely necessary for life-threatening bleeding.
Number 6, Be extremely cautious with warfarin. It's contraindicated acutely and requires specific criteria for initiation, platelets 150K for 2 days, and a careful overlap period to prevent catastrophic complications like venous limb gangrene.
And number 7, DOACs are emerging as a potentially safer and more convenient option for transition and long-term anticoagulation after platelet recovery, avoiding the warfarin pitfalls. Duration depends on thrombosis, at least 3 months for HITT, at least full weeks usually for isolated HIT.
Excellent summary. That brings us to our final provocative thought for the audience to consider. We've talked about the standard monitoring with APTT or anti-elasta levels for the parenteral agents. But given that persistent thrombotic risk even after platelet recovery, and the shift towards DOACs, which don't have readily available monitoring assays for intensity, how might we refine our strategies in the future, especially for complex patients?
That's a great question. Could we develop better biomarkers or functional tests beyond just platelet count to gauge the ongoing level of prothrombotic risk after acute HIT? How do we better personalize the duration of anticoagulation, particularly in challenging populations like the critically ill or patients with cancer, where baseline risks of both clotting and bleeding are already high, and diagnosing HIT itself can be difficult due to confounding factors? Moving beyond one-size-fits-all durations towards more tailored therapy based on residual thrombotic risk seems like the next frontier.
Something for us all to think about as the evidence evolves. Thank you. This has been incredibly informative.
My pleasure. It's a vital topic for all of us practicing hospital medicine.